Welcome back to another Biomedicine webinar. I've lost track of how many we've done. We're on 20-something, that's for sure. So thank you so much for everyone who has joined all of our previous webinars, and to all the newcomers as well, who are joining us for this fantastic week of special guests. Welcome to all of you as well. For those of you who don't know me, my name is Azim. I'm a junior doctor in central London. I completed my academic foundation program at Guy's and St Thomas's Hospital, and co-founded Biomedicine with a bunch of friends of mine around a year and a half ago. And we've been offering these free webinars for you guys throughout COVID-19. So thank you for all of your support. Before we dive in and I introduce our very special guest, just a few housekeeping bits and pieces. So in terms of certificates, you are now able to receive certificates per webinar you attend due to our collaboration with our friends at Medigate. Please ensure you check your junk mail. These are sent out weekly, so there is a slight delay, so thank you for bearing with us in terms of that. Also, please ensure you tell your friends, tell your family about us. The only way we can continue these is if people keep attending. So thank you very much for being here today. We're really grateful. I'm sure there's hundreds of other things you could be doing right now. And also check out our website, www.biomedicine.com. Okay, Arjun, would you mind popping over to the next slide if that's all right? There we go. Okay, brilliant. So before we dive in, what I would like to do briefly is introduce Dr. Arjun Thor to you. So Arjun is an A&E consultant at Guy's and St Thomas's Hospital. And before I go any further, Arjun, can you see the chat? You can see?
Yes.
You can. Okay, so before we dive in, it was Arjun's birthday yesterday. So can all 400 of you please wish him happy birthday in the chat? I'm sure that would make his day, week, month, and potentially his year. So thank you so much for being with us today, Arjun. We're so grateful. Happy birthday. I'm sure there are lots of other things you could be doing today, but we're so happy to have you here today. So thank you. So Arjun is, it was an absolute pleasure. I've worked with Arjun throughout my A&E rotation as an F2 at Guy's and St Thomas's. And he is actually one of the youngest consultants in the history of A&E at Guy's and St Thomas's, as you can tell how young he looks now. So, and he's also one of the best consultants I have ever had the pleasure of working with. He is super supportive. A&E is a very stressful environment, so just getting constructive criticism from someone without them shouting at you is an absolute pleasure. And he's always super calm under pressure. Whether it's kind of going for brunch after our night shift or whatever it is, you know, he's an absolutely amazing consultant, and we're so glad to have him here today. And thank you, Arjun, for joining us and imparting your knowledge. So Arjun's going to be going through some mind-boggling cases for us. I think the first case here actually had the pleasure of being in, well, not the pleasure, is actually one of the most harrowing experiences of my life, but I was involved in the first case as well, which is where Arjun and I kind of bonded following that. So I'm going to hand you over to Arjun, and we're going to have a Q&A at the end as well, where you guys can ask him all of your questions. So thank you once again, Arjun. I'll hand it over to you.
Thank you, Azim, for that introduction. Thank you, everyone. Thanks for all the lovely wishes.
Thank you.
So yes, so what I'm going to do today is talk to you guys about working in A&E. It is a really good experience because you don't really know what's going to come through the doors. So what I've got today are two cases which I felt really fit the bill, saying mind-boggling. So we're going to start with the first one. Let me just change the slide. Yeah, so case one. This is a 19-year-old male who was dropped off at the ambulance ramp outside the emergency department, actively bleeding. Now, just a quick introduction before we go about it. A&E resus, how it works is you get a pre-alert, and that's how the patients come in. So you know, and you get time to prepare while you're waiting for the patients. But this patient basically was just dropped off. So no one had any idea what's going on. And then security was called because of bleeding. He was brought in then into the resuscitation room on a trolley. and had rapid shallow breathing and was semi-conscious, not really responding much, not talking. The initial observations done showed a heart rate of 140. The blood pressure was not really recordable, and a rest rate of about 40. So the most important thing that we do in emergency medicine, especially when you go assess your patients, is ABCD, very simple. So the ABCD assessment performed by the registrar on patient was, as I said earlier, not really talking, but was semi-conscious, but airway kind of maintaining, was breathing very, very rapid and shallow. And I've mentioned already the circulation and the GCS about would be about 7 or 8. And what the most important thing we found on exposure, that's E, was a stab wound anterior to the chest. And that was the most important thing there, identified as to why he was bleeding. So I'm trying to change the slide. Next steps. So because this was a penetrating thoracic injury, we activated the adult trauma team. And also because he was actively bleeding and hemodynamically unstable, a major hemorrhage protocol was activated. Now the adult trauma team consists of, because there's an ED registrar consultant already available in the emergency department, it will also alert the orthopedics, this general surgical team, gets you anesthetist, and also activates, if needed, for example, any specific specialties. For example, in this case, because we knew it's a penetrating thoracic injury, it was put out as a penetrating thoracic injury, and luckily, we also got a cardiothoracic registrar who was alerted as part of the trauma team. The major hemorrhage protocol, this is activated when you identify patients with hemodynamic instability and ongoing blood loss. What this basically does is gets you access to all the blood products very quickly, very rapidly. We do stock about 2 units of O negative blood in resus area, but what we really need is not just packed cells. You also need fresh frozen plasma, FFPs. You also need platelets. So this is what gets you when you activate this call through the transfusion lab. And also, this is possibly more specific to Guy's and St. Thomas's where I work, where it's also alerts the hematology registrar on call, and they start talking to the doctor who's running the cardiac arrest or the trauma call to say what are the blood products really needed and what are the things we need to do. So what happened next? So the patient actually arrested, so cardiac arrest was declared, ALS algorithm was initiated, chest compression started, we're trying to get access. The trauma team had arrived, so the anesthetic registrar really took over the airway, knew the arrest, intubate the patient as early as possible. The cardiothoracic registrars attended, as I told, because it was a penetrating traumatic injury put out as part of trauma call, and we identified there's a stab wound to the anterior chest. So what we really need to do is emergency thoracotomy. Now, this is absolute indication where you have a penetrating chest injury and patients come in, possibly peri-arrest, and then has a witnessed cardiac arrest. These are the 2 important indications where you say, yes, you need to open the chest as soon as possible, which was done. We did have the O negative blood available, and as part of the major hemorrhage protocol, this was transfused along with fresh frozen plasma and platelets. And a clamshell thoracotomy was done. I'll talk about this as we discuss further. What clamshell thoracotomy really is. Next. Sorry about the slides, it's just taking some time. Yeah. Now, once the clamshell thoracotomy was done, what you actually then see is the heart. And really, you want to identify what is this a blood vessel? Is it injury directly to the heart? What is exactly bleeding? What's the source you want to see? Because all you want to do is find the source of bleeding and apply pressure. So at this point, what they could see was the heart. So they started doing internal defibrillation and internal cardiac massage. And the descending thoracic aorta was clamped to prevent further blood loss. What happened next? Now, what we were getting after this really was minimal cardiac output. There was a feeble carotid pulse. So the patient did respond, I would say, to the internal cardiac massage and the defibrillation and the ongoing blood transfusions. But at that point, the patient was too unstable to transfer to theater. So if I have not mentioned earlier, it was actually, this is about 6 or 5:30 in the morning, and it's normally at night. You would have emergency department, a registrar who will be the physician in charge. There is a consultant, and they're on call from home. But need be attend. And this is exactly, and I was a consultant on call, and I got this phone call saying that this is what's happening and I'm needed. And basically you have to respond as early as you can. And similar call went out to the surgical consultant, because what we really need is damage control surgery. So the surgical registrars and the ED registrars were running the call, and we attended. And while we came into the resuscitation area, looking at the fact that there was some cardiac output and there was some cardiac activity with a feeble carotid pulse, the decision to perform emergency laparotomy in resus. Now, this is something which does not happen really, because a resuscitation area and emergency departments is designed for trauma, is designed for possible thoracotomies, but not essentially designed for laparotomies. This is where we transfer patients to theater, really, because it's deemed more controlled environment. However, this patient was too unstable, as I mentioned earlier. And so we said, I think there's still possibly a chance, let's do this here. And we had all the equipment, the theater staff, we had the equipment delivered while this was going on. And the emergency laparotomy was done by the surgical consultant and the registrar. Mainly with damage control surgery, what you're looking for is you're just packing as much as you can, because there's blood everywhere. And that's what happened when we opened the abdomen. There was blood everywhere. We don't know the source of blood, what's happened, because what we really don't know here is, yes, this young man's been stabbed. We don't know when, how, what has happened, what weapon was used, how sharp the knife is, nothing of that sort. So we really don't know the track of the wound, what vessels have been injured. So we packed as much as we can, but unfortunately there was no cardiac output after that, and no cardiac activity. And then a combined decision made by myself and the surgical consultant and the rest of the team to stop and end resuscitation at that point. What followed really after this is, which we do in an emergency department, especially after this case, is a debriefing, because there's so much emotions, there's so much of adrenaline really when you're running this call. So we divide the debrief sessions into hot debrief and a cold debrief. Hot debrief is something that happens immediately after, so that people do get to talk and share what they thought about it, what the process was. It's just more about trying to vent, because you feel, was this right, was this not right? And it's more so just talking through what's happening really. And after a few days, what we try to then organize is called a cold debrief, where then we really get experts or a third consult from a third party, just to get an idea about what other things we could have done differently, and you may mainly use it as a learning process. So we talked about emergency thoracotomy here, which is possibly new for some people. Some people have seen them on television. Someone have seen them on videos or actually witnessed it in their postings. Emergency thoracotomy is, as I absolutely mentioned, absolute indication is witness cardiac arrest and penetrating thoracic injuries, really. There is a few relative indications which you can say is blunt trauma, and there was, the patient was talking, really, they say, and then you have witnessed cardiac arrest, then yeah, you could consider, but absolute indication would be that. Now, coming to types, again, there are different types. The one I've mentioned here was clamshell. So I'm going to talk a bit about this. Next slide. Sorry. Oh, yeah. So clamshell. So this picture really just tells you what exactly is happening. It's actually like clamshell, where you are making incisions bilaterally on the chest wall. Okay, it's easily done when two people do it. So if the cardiothoracic registrar is on one side, the general surgical registrar was on the other side. And basically what you're doing is you're combining these two the incisions that you do on the lateral side, and you open up the chest, and you've got the equipment to really lift off, to expose the heart and the major thoracic vessels, because that's what you're worried about, that would have been injured. The other one is the left anterolateral thoracotomy. This is something which is done, again, a lot in emergencies, just because it's quicker. And if you have just one person who's trained, this is something which you would jump and do. If obviously you've got, because this will give you the access to the major vessels and the heart. If you have got two people who can do it, which fortunately we had in this case, you possibly do the clamshell because you just get more room. Because what you really need to understand, it's difficult to imagine, but there are a lot of people as part of this trauma code. There are a lot of people helping out with the hemorrhage protocol, the trauma teams there, you get emergency department nurses, you've got the theater nurses, you've got the anesthetic team. So it's a lot of people in limited or confined space. So then you need as much room as possible, really. So that's what I would want you guys to understand as the importance of doing the clamshell. And what's most important is to be the trauma team leader, which was marvelously run by my registrar, who's now a consultant with us. Really, really well run. And then what happened was when I came on and took over, again, that's really good way of handling the situation, because you sometimes get too fixated and you don't know what is going to happen next. And that's what really helps when you have got that leadership role. So this is about thoracotomies. The other indications, if you go through ATLS, which is the Advanced Trauma Life Support course, which is being done by the American College of Surgeons and also done by the Royal College of Surgeons in England. They basically give other indications of thoracotomy would be if a patient, a patient with major trauma is showing ongoing blood loss, has a hemothorax, blood in the chest cavity, and you put a chest drain and it continues to drain more than 1.5 liters of blood, or about 200 mils per hour of blood every hour for 3 hours. Those are the other indications for thoracotomies. And in those situations, what you end up doing is the left anterolateral thoracotomies, because you would have done, in order to put the chest drain in, which you can see in this diagram, you basically would have done a thoracostomy, which is more just the incision to put the drain. And that's can easily be then extended into a thoracotomy, which you can see in the diagram. Yeah, so that's about the first case. So yeah, unfortunately, the outcome wasn't what we wish for as doctors, but what we can say is it was indeed tragic, a young life lost. We couldn't really get much information as to what has actually happened, and what was the reason for the knife crime. It did actually, as part of the debrief, what we really talked about was how good the trauma call ran. Were there any issues with the major hemorrhage protocol, with the trauma team? And it seemed like even if this would have happened, let's say during the day, if I or any of the ED consultants would have been there, I don't think there would be any difference into the way it was ran at that time at like morning 5 or 5:30 in the morning. So yeah, the team had done a really good job. And it was really good to then, because what you guys need to really understand is something like this happens, you still have to have the hospital open because the emergency department can't close. There's still sick people coming through the doors. The security play a really important role in this case because police have to be called. There's a knife crime that's happened. We don't know if the perpetrators are still out there. Are they going to come to finish that? There's just so much more to it, just apart from the medicine of dealing with the emergency. So that was really well handled, and that was talked about in detail. So yeah, so this is our case one. Moving on, I'm going to talk to you about the next mind-boggling case. So yeah, this is again, so I think possibly I've taken, these two cases are really close because I was the one who had to deal with them, and they are young males. And I think we predominantly have this kind of population come to the Rose Guys and St. Thomas's, possibly because it's central London. So this is a 22-year-old male who's brought to the emergency department by ambulance. He was found, so we did get a pre-alert for this patient. The basic what happens is you have a red phone in the, it's like 24 hours in A&E really. You get a red phone that rings, and then one of the nurses answers, and we get an ETA, estimated time of arrival, 9 minutes, and we get the vital signs, and it gives you really that 9 minutes just vanish because all you're doing is you're trying to prep the team. You're like, okay, right, what's going on? What are we getting? You kind of get a pre-alert. So in contrast to the previous case, we know what was coming to us. So again, Guys and St. Thomas's is the toxicology center. So we do get a lot of drug and tox presentations. So this was similar to that, found in a nightclub. Was semi-conscious, quite hot and sweaty, and someone had just found him collapsed. The patient arrived into the resuscitation room. The paramedics had given us a quick handover, really. They give us the vital signs and they just tell us what briefly they know, and that's exactly what they knew. The patient, not much, past medical history that they could elicit from him. He was by himself. There were no friends to give us any more information. So on the ABCDE, so it's always ABCD, it's quite clear. Yeah? In emergency medicine, everything's ABCD, keep it simple. So did the ABCD assessment, airway, his GCS was low, so he was not able to protect his airway. There were secretions, and we established that, yes, this guy needs airway management as early as possible. He was breathing, his rest rate was just 8, so he was not really making much effort. Respiratory depression. Circulation, he had a heart rate of 130. He was quite hypertensive at 180 or 120, very diaphoretic, sweaty, and had a temperature of 40. So really hot. And his GCS was eye-opening of 1, verbal 1, and motor response 4. And while checking his motor response, really what we established was he had increased muscle tone and really rigid. And we were like, what's going on? Did he end up having a seizure? What's going on there? And his pupils were really dilated, 5, but reactive, but 5. So our next steps, we immediately established that he needs airway protection. Anyone with the GCS of less than 8, we deem that they are unable to protect that airway and really need to protect. In his case, he had copious secretions. That's even worse because they'll end up aspirating, and that is the most likely cause of the cardiac arrest. So the decision was to intubate to protect airway. So airway call was put out. So you get the anesthetic team of fast bleed, and you get the registrar and the ODPs, which are the airway nurses, practitioners really, who help the anesthetist with the drugs and with all the airway kit that's needed. So on the right side of the screen, you can see what the ECG was done. So we are very good, especially in resus, to get 12 lead printed ECGs as quickly as we can as soon as patients come in. And what you can see on the right side of ECG is you see the peaked T waves, which are quite important because that the first thing you can think of as soon as you see peak T waves is hyperkalemia, which you can see on the VBG results. So IV access was put in, we got the bloods out, and what you can see is the pH of 7.0, normal pH being 7.35 to 7.45. So this patient was quite acidemic, with a bicarb again really low. You see, like the normal values for bicarbonate is 23 to 29, and you can see that his bicarb is 8. So I'm actually surprised he was still alive. And a potassium of 8.1, where a normal range would be 3.5 to 5.2. So you can see in raised temperature, he's basically in a catabolic process, really sick, really unwell. So our next steps, what happened next? Active cooling methods were initiated. Now we'll talk about a bit about active cooling. It's when we say active cooling is you really need to do some good intervention. So what you can do in an emergency is, apart from just giving fluids, cold fluids, because you can't really overload people that much, you can't really give so much fluid because you'll end up causing a fluid overload. So what you try to do is any cavity that you can find, you just try to wash it with cold fluids to bring down the temperature. So in this case, we catheterized him and started to do bladder washouts. Cold water, you put NG tube in. Some people have tried active cooling measures, have been where you could actually put chest drains and then, wash out, because you really need to bring that temperature down. What was most important, life-threatening emergency here, was hyperkalemia. So the treatment for hyperkalemia, especially life-threatening hyperkalemia, the value that he had was 8. We gave him calcium gluconate. And what calcium gluconate does is basically it's a cardiac stabilizing drug. So it actually pushes the potassium intracellularly, and that's the same mechanism with insulin dextrose. So the insulin dextrose, technically what it does, how it works, is it pushes the potassium intracellular, so just reducing the levels of potassium that are circulating. And this was given back-to-back doses were given to bring down the hyperkalemia. I already mentioned we catheterized him, inserted an NG tube. Now the reason to, apart from just for the fact of putting the NG tube down for one, active cooling, for the fact that he's obviously intubated, and possibly if he's out there partying in a nightclub, possibly has a full stomach, possibly he's been drinking, possibly had drugs. So you know that it would be really important to deflate that stomach. Also very important is a drug called cyproheptadine, which was given to him, 12 milligram dose. Now this is really done, and this is what we're talking in detail about. What was happening here is serotonin syndrome. So basically, a cyproheptadine blocks these serotonin receptors and should be given early when you have identified what's going on. So what's basically happening with him is something called drug-induced hyperpyrexia. And the pH of 7, not good at all. So he's in severe metabolic acidosis. So we have to give him sodium bicarbonate infusions, 8.4%. You can give them in 50 to 100 ml boluses, and that's what we were doing. And what you basically are, that doesn't end there, because giving the hyperkalemia, like treating the hyperkalemia, that's really just temporizing measure. That will not push that potassium of 8 to any lower. So what we then had to do was decide what's going to happen. So if this happens really quick, yeah, the anesthetic team's there, the patient's been intubated, this all is going on. I really want you guys to imagine this in a busy research department. And I was there, so this is where I have been there in the research department. And so you're speaking to the ITU consultant, the critical care consultant, they're coming down. You're speaking to our toxicologist. So we have toxicology consultants 24 hours on call at St. Thomas's. So we're calling them because I don't know what drugs he's taken. We have no idea. We talk about something called toxidrome, which kind of gives you an idea of what you think the most likely drug is. So if the patient's showing high temperature, he's in a serotonin syndrome, possibly he's taken amphetamine, MDMA, whatever you call it. I don't know the actual, what's it called on the market or in a club? How is it sold? Blue pill? I don't know. And we don't really know. So we just guess that this is most likely the drug that's this man has taken. So what you really then do is just, what you're doing is supportive measures, as I mentioned, of all of this, because you really don't have an antidote for the toxin. So the VASCAT, now VASCAT is basically a dialysis catheter, because what you realize is this patient's too unwell. He's not arrested as of now because he's getting all the right treatment. So we're kind of keeping him alive, and he still has a pulse. He still has a cardiac output. And basically we know where he's heading. With that hyperkalemic, that metabolic acidosis, he needs to be dialyzed. His kidneys are not going to take the. What's happening is basically, it's just what you can see is increased muscle breakdown. He's got loads and loads of myoglobin there, which is damaging his kidneys. And the increased muscle breakdown is basically causing hyperkalemia. And so the plan is to hemodialyze him urgently, and that'll happen in critical care. So we get him on transfer to critical care. Now, this is what my experience was of him. So I've just stopped it here, but he's from the critical care side of it. He's gone on to critical care. He didn't really do well. I think tragically he died eventually. I think there were talks that they tried to cool him. He was dialyzed. There were discussions of ECMO, but unfortunately he didn't survive, and he died the next day. So it is, I'm sorry to share these two cases, which unfortunately didn't have a good outcome. But I think it's really important to tell you guys this, because we work really hard as emergency physicians. We don't have much time. And I think it's part and parcel to realize that you do work hard, but at the end of the day, if things don't work out, they don't work out. And it's kind of hitting that balance to accept that, yeah, you could have tried, but it won't change the outcome. But yeah, you still try your best to do whatever you can. So I'm going to take it further from here. Next slide, where I'll talk about what drug-induced hyperpyrexia really is. So bear with me. Yes, so drug-induced hyperpyrexia, really hot. So drugs, I kind of mentioned amphetamines, all the serotonin-releasing drugs, really. Cocaine also does this. MDMA are quite on the market, and they basically what they do is activate the serotonin receptors. So there's a lot of serotonin being released and causing all the side effects. Serotonin syndrome is what we call it. So it's marked by exactly what the patient presented with. They're tachycardic, hypertensive, really increased muscle tone, really spastic, and they end up actually being very, very agitated. I think this guy has passed that agitation phase because he was really semi-conscious, like not really responding. But they actually can be so agitated that they need a really large dose of benzodiazepines. So that's when we say benzodiazepines are your friends when you're managing serotonin syndrome, especially when you're managing drug-induced hyperpyrexia. And it's a catabolic state where everything is just breaking down, and there's myoglobin, there's hyperkalemia, and renal failure, metabolic acidosis, and there's a lot of management required, which we tried our best, to be honest. So the management principles. So most important is removal of the precipitating drugs. Now this can be really difficult because possibly you can say, dialyze this patient and you can get the drug out. That'll be the quickest way. But again, we don't know the absorption. We don't really know what kind of make it is. How is it being manufactured? These are just something people find in a nightclub or what's going on. But if you identify the drug, then you make sure you try everything to remove the precipitating drug from circulation. Provision of supportive care, which I've kind of explained. You just are doing cooling measures. You just really need to support the airway because you're worried that, this patient is so unwell that they can't protect their own airway. So you need to plan early intubation, aggressive fluid resuscitation, to be honest, because all you want to do is help to release this drug out of their system. Control of agitation, as I said, they're very agitated, so you need large doses of benzodiazepines, diazepam, really, to help, because otherwise they end up having intractable seizures, and you literally see that you're unable to control their seizures with antiepileptics. So all you need to do is give them good amount of sedation. And it's also very important to know that in this state, serotonin syndrome, very important to know that there's certain anesthetic agents that you can't use because, for example, inhalational anesthetics. So when you have elective surgeries, what anesthetists try to do is use these gases as general anesthetics, which you can't use, especially with serotonin syndrome. Also, a very common drug used in intubation is fentanyl. Again, fentanyl works through serotonin receptors. So that's something you're not supposed to be using because you're just gonna increase that already catabolic state and increase the free circulation of serotonin. And I talked about the cyproheptadine. So cyproheptadine is really important because it's serotonin antagonist, and it's really your friend. You want to block those receptors so the serotonin can't act, really. So that's why you give large amounts of cyproheptadine. Fortunately for us, we had it available. The tox consultant was definitely on it. He said, we need to give it as soon as possible, and it has to go oral. That's the problem. So obviously, if the patients are intubated, you have to put in a nasogastric tube. That's really important to put the feeding tube, the nasogastric tube, and administer the cyproheptadine, which we did. And really, the most important point here is the control of this autonomic instability. Again, it's very difficult. Like, you could give large amounts of diazepam, aggressive fluid resuscitation, but there's just so much going on, really. Like that tachycardia, it can precipitate arrhythmias. You can have really high heart rates. So a lot. The heart is really unstable here, so there's a lot to manage, and the control of hyperthermia, again, really important. That's why the active cooling measures are really important. As we said, any orifice that you can find, you really need to just give large amounts of fluids and like do bladder washouts to help reduce that temperature. So I just saw a quick chat. It's just ECMO. I know I mentioned ECMO. I didn't, so it's extracorporeal membrane oxygenation. This is usually done patients who have arrested and not prolonged cardiac arrest, but very quick cardiac arrest, as in the onset time is short down time, and you can then basically bypass their oxygenation circulation through machine. Hence, they do have a better survival rate. But again, you can try. That's what we say. You do put them in. It's not always success stories. So that's what was tried on this gentleman. Next slide. So just a recap. I've spoken to you today about these two cases, which really are quite close to me because I think I learned a lot from them. It's just because as I mentioned earlier, you feel you've got a CCD, you've completed your training in emergency medicine, you've been working as a consultant, but you still are at that point where you see something and you're like, oh my God, could I have done this better? Did I not do everything right? And then you have discussions, and there's just so much learning. And then you've got this whole lot of team there, doctors, nurses, physician associates, advanced clinical practitioners, and you need to be the leader who then has to do the debrief, talk to them, see what, and then talk to the family. And it is challenging, but I love my job, and that's why I wanted to share it with you guys today. So recap, basics of emergency thoracotomy, really important to know what it is. I would definitely recommend all of you to go through the resources I'm going to share later about like what are the indications, what's the procedure like, and if you are going to be, clinical attachments or clinical roles, whenever you are going to get back to doing that, definitely I would say is something you'll be fortunate to witness it, because it's quite intense, but it's so much to learn, and a really good experience. Importance of ABCD assessment, really important. As at the end of the day, you can be a surgeon, you could be a physician, you could, whether you're a medical student, whether you're FY2, FY1, whether you're CT, higher trainee, registrar, SHO, consultant, this is the most important ABCD assessment. So I can't emphasize enough on this. Will exactly tell you, give you a structured approach to identify the problem, and you will never go wrong. So always stick to ABCDE. Drug-induced hyperpyrexia, again, really interesting. There's just so many causes for it, and I'll share in my further learning resources. There is actually a module on RChem learning, which you can, if you want to go through it, that's really good. It talks a lot in depth about drug-induced hyperpyrexia, and always think of it, especially with young adults who come in on drug overdoses or from nightclubs. So that's my further reading slide. www.rchemlearning.co.uk. Don't think you have to be an RChem member for this. They do have some free resources also, so you can go to that. Life in the fast lane, that kind of describes what we do, what I do day in, day out. So this is my go-to site. It's just got so much learning resource, such good ECGs. It's just literally name it and they have got the information. So I would definitely recommend going through that. Talkspace is password protected. So if you guys attach, you can ask your friends or colleagues or mentors, because it has a username and password, but it does cover more, like all the toxins that I've come across. To be honest, there'll be something about how to manage, and it talks in depth about managing drug-induced hyperpyrexia. And advanced trauma life support. This is obviously a paid course, which you have to do, especially you can do it as a foundation year trainee, but they do have resources available out there which you can access to. And it's really important to know about, they talk about indications for thoracotomy and major hemorrhage protocol in depth, which I've just touched on, to be honest, just because I'm sharing the experience. I'm not really talking about major hemorrhage. So this is, I would definitely recommend further reading on that. And yeah, so that's the end of my talk today. I hope you guys have enjoyed. These are the references which I'm gonna show.
Hello, Arjun.
Yeah.
Hi, thank you so much for going through those two fantastic cases. Really, really interesting. I'm sure everyone has learned so much from those, and clearly they've both had a big impact on you as well. So yeah, thank you so much for, I think, going through that first case gave me a lot of flashbacks as well, the thoracotomy and laparotomy case. So thank you so much for that. So what we're going to do now is, Arjun, do you mind just flipping to the next slide, if that's all right?
Yeah.
Brilliant. Okay, so there is going to be a full interactive Q&A, which Arjun has kindly agreed to go through straight after this slide. So please stick around for the Q&A and all of your burning questions on how to become an amazing consultant like Arjun. There are some doctors in the chat as well. Hopefully Shwaib is going to be posting the feedback link now. If you'd like to fill out the feedback forms, you can do that as well. If you fill out one, you'll get a certificate as well. And also what we're trying to do for this Q&A, there was a lot of feedback in terms of to kind of taking quite a long time to go through each question. So we're going to try something a little bit different now with lots of questions on the screen. And if Arjun, if it's okay with you, I'll pick some out as we go along and you can answer those. Does that sound good?
Yep.
Fantastic. Okay, so let's try this. Hopefully this works. Can you guys see this? Yeah. Let me see the chat. Where's the chat gone? Okay, can everyone see my screen? Yep, brilliant. Okay, do you mind if you head over to menti.com and type in the code 480884. We will try out this Q&A and hopefully it works. Yeah, there's the feedback form. We obviously won't be able to get through all of these probably hundreds of questions, but we will try and get through as many as we can. And Shwaib will be answering and mopping up as many questions as he can in the chat as well. Okay, I think question number one is probably the most burning question. Arjun, tell us your big secret. How did you become a consultant so young?
Right. I think it was just run through, to be honest, right from med school to foundation year training and then straight on to emergency medicine training. I've not taken any time out, to be honest. I always knew I wanted to do emergency medicine. So I think that's also, if you are very sure early on in your medical career as a medical student, then I think it really helps possibly to get there. But I wouldn't recommend that, I would say you need to really try and know what you really want to do. And the only way you're going to get that is when you actually start working, you're clinical, and then you have to decide what's your interest, really. So EM worked for me.
Great, thank you. So I think a couple of questions going back to your second case there. So if we go to this one here. So any general tips for managing suspected drug overdose coming to A&E? Obviously, it's kind of remarkably common, particularly in central London, these presentations. Any general tips?
Yeah, so I touched on that. Most important, always remember ABCD approach. This is something we always forget and we get fixated onto, is there a special antidote? It's always supportive measures that's going to help the patient in the end and improve the patient outcome. So ABCD approach, as long as you're managing patients' airway, giving them oxygen, fluid resuscitation, and monitoring their sugars, that is the most important thing. And then, as I talked about, the supporting measures is something that will improve the patient outcome. And then, based on the toxidrome, like if you can identify what drug it is, what toxin is, if you have a list of antidote available and you can give it, then yeah, definitely then that. The most important website that everyone's aware of, we use it a lot, is Toxbase. In addition to that fact that we have access to toxicologists that help us a lot. But yeah, most of it is covered in Toxbase. So they clearly give you what exactly you need to do, how much a period of observation, even if the patient looks okay, the period of observation that's needed. So yeah.
Okay, brilliant. Thank you, Arjun. So kind of, it seems like there are a lot of people here potentially looking to go into a career in emergency medicine. We've got this one here. What is the biggest challenge, or maybe a selection of challenges that you face as an A&E consultant? Any that spring to mind?
I think the biggest challenge, to be honest, is the work-life balance, because what you really need to know is you still will have to predominant time of your work time is clinical. You have to do out of hours, which is outside the normal working hours. You have to cover weekends, because any department never shuts. Even in COVID times, current times, emergency departments up and running, and it gets busy. And as I talked about these two cases, sometimes you don't even know what's coming through the door. So you really have to, if you really like that, then yes, this is a career for you. I feel it definitely gives you that satisfaction that, yes, you're making a difference to the patient's life.
Okay, lovely, amazing. I think that's probably going to be linked into some of these questions about why you went into a career in emergency medicine. Probably, is there anything else you want to add about that question? Why you went particularly into a career in emergency medicine?
So emergency medicine for me, so I trained in India. So I did my med school in India, did my foundation year training. And then during my medical school, clinical attachments, that India at that time was, emergency medicine wasn't really recognized as a separate specialty. So it was called casualty. And I think that's what really got my interest as to developing emergency medicine. When I could see in the UK, there was so much happening on emergency medicine, and in the US and in India, we were still in that casualty kind of thing where there was no specific guidelines, there were no special emergency specialists. So that really interested me, and I was like, I can definitely go into this field and really try establishing this. And now emergency medicine is a recognized specialty in India. There's a training program. So I think that was the main driving force for me.
Yeah, brilliant. Thank you. There are a few questions here about the second case in terms of serotonin syndrome. I think just a brief explanation, I think people might benefit from, if that, like a little explanation of serotonin syndrome.
Yeah. So serotonin syndrome is basically, it can happen, as I said, it's mostly drug induced. So in this case, I really talked about recreational drugs, which you don't have to have an overdose of recreational drug. It could be just the normal therapeutic levels, and it could cause this. So you don't have to always think of drug overdose as causing serotonin syndrome. What serotonin syndrome mainly comprises of is there is overactivity, because there's serotonin release in the body. And because of this, it leads to a catabolic state, which I said, which means nothing but increased muscle breakdown. These patients actually are quite hypertensive, all the effects of serotonin, tachycardic. And because of this, they become, there's muscle breakdown, there's rigidity, increased muscle tone. And this muscle breakdown releases the myoglobin, and this is in turn called rhabdomyolysis. Now, the increased amount of myoglobin that's released, the muscle pigment that's released, then affects your kidneys, because the renal tubules can't really accommodate so much of muscle protein and pigment, and hence leads to renal failure, in turn causing metabolic acidosis and really catastrophic renal failure. Other side effect of this state is hyperkalemia, and that's what we saw in this case, really increased levels of potassium, which then can't be managed just by giving intravenous drugs, because it's all temporizing measure, as I said. So what you end up then doing is dialyzing this patient because the kidneys stop working. And hence that's why you get this catabolic state.
Thank you. Brilliant. Very, very thorough explanation. So I think this is a very interesting question. One that I think is very, very relevant. I think what you mentioned earlier about, both of these cases unfortunately ended up in both patients dying. But I think, like we had a brief chat about before we were preparing these slides, is that actually that is a reality of emergency medicine. Do you have any advice on how someone should, or how you manage the emotional aspects of traumatic cases like these?
Yeah, so this is really important. I'm glad this question is a really good question, to be honest, because emergency medicine career you'll have to really understand that this is going to be an important aspect. The best way, how I deal, I can give you that, is you need to switch off. As soon as you get home, you need to switch off. It's difficult. It's easy to just say switch off. It's not that easy, but you need to. You can't take your work home, because it's going to affect your personal life. It's going to affect your relationships. You need to switch off. What we really try to do is at work, if something like this happens, as I mentioned briefly, is about something called debrief. Now, debrief helps because then you all talk. It's not about pointing fingers. It's not about the surgical team didn't come, this didn't happen, you should have done a better job, I didn't do a better job. It's not that. It's just about talking your experience. So, and there's no that I was the consultant, so you can't talk to me like this. You're a SHO or you're a nurse, you can't talk to me. Everyone's equal. So everyone just says, you know what, I felt this could have been done differently, or I really like this aspect of it. It's just, you realize when you do that, just immediately after this cardiac arrest or a trauma scenario or anything like that, it really helps you that you were heard. And that's, I think, what helps mostly.
Yeah.
And as I said, after that, what we do is we always follow it up with a cold debrief where we get it, we do it as a teaching process. And that helps because then people have had that time to, you know, digest that information and kind of get over it and then talk about and get the learning out of it. And what we've seen is more and more supportive groups that have been set up now, especially for emergency medicine doctors. So you have, you know, you can attend these sessions, one-on-one sessions, which are available. And it's mainly talking about well-being. It's just targeted on mindfulness and mental well-being, which really helps you because emergency medicine, as I mentioned, is a really high-pressure job. So you really need to prevent burnout, as we call it. You need to switch off. And the best way to do this would be if you have allocated time for mindfulness, then at least you know that there has been someone you could talk to. That's what I would recommend.
Absolutely, all really, really good advice. Thank you for sharing that. I think particularly, obviously, I only did F2 as an SHO in A&E. Like when you go from a transition from a specialty, which is probably a little bit more relaxed, and then chucked into A&E, I think, you know, learning to manage the emotional aspects inside of the job are really, really important. So thank you for sharing that. I think kind of linked into those non-technical skills, like, you know, managing emotions, communication are very, very, you know, coexistent. I think this is a really good question. I think obviously we were both involved in the first case. I remember, you know, lots of different teams are involved. You've got anaesthetist at one end, cardiothoracic surgeon, general surgeons. There were so many different teams. You've got the hematologist come running downstairs asking why you haven't checked the prothrombin or whatever. And, you know, glass vials being chucked around, blood on the floor. In these very, very stressful situations, any advice you would give on the main ways to ensure good communication?
Yes, so I think I touched upon this. I said it's really important to identify a team leader because there are just so many people around there. Everyone's trying to help. No one's making it difficult. But if everyone talks, then no one's listening. Everyone's talking. So you really need a team leader, whether it's a cardiac arrest and you have a cardiac arrest team leader, whether you have a trauma team leader, or any kind of emergency. You always have to identify one person as the leader, who then will be calling the shots, as we say. Yes, I'm going to listen to everybody. I'm going to so if I start with the ABCD approach, I'm going to listen to the anesthetist saying, are you happy with the airway? Yes, are you happy with the breathing? Right. Then I'm going to move on to my ED registrar. I'm going to be like, are you happy with circulation? Have you got all the IV access? Have you got fluids running? Have you got blood? So you allocate roles and you have to have a closed loop of communication where if I allocate a task to you, I would want to hear back. Have you done that? So if I say to the blood person in this trauma case, listen, this man needs this much blood. I need to hear back, yes, I have transfused 2 units of blood. How much more do you want? And that's what incorporates really good leadership skills. There are courses actually available, trauma team leader courses, which I would definitely recommend if you can attend, because it kind of talks about the non-technical skills, as we mentioned, which is really important. And when you're dealing with other consultants, for example, like the surgical consultant, I think the first case, it was really good because we both were like, this has never happened. We have not done this. You know, we normally never done laparotomy in resus. And he was saying the same. I said, I have not done this in my experience. But he was like, there's a chance. I was like, to be honest, let's do it. And I think this is what is really important when you can make really time-sensitive decisions if you have good communication. And that was a good example.
Okay, great, amazing. Really, really good advice there. I think kind of linked into that even, Obviously, they're going to be, I think initially we had hundreds and hundreds of students here. We still have a couple of hundred here. Majority of whom are going to be either medical students or physician associates. Do you have any advice for either medical students or PAs on what they should do or what they should gain from their brief A&E rotations?
Yeah, so I am the undergraduate lead for emergency medicine at St. Thomas's, and I always tell my students, this is your best opportunity to get the taster. I know a lot of people say, we want a taster session to decide whether it's the EM is my career choice or not. But to be honest, this is your best choice while you're there. So even if you are, let's say, I think resuscitation, resus, as we call it, is what everyone wants to go. Now there's limited space, but I would say every area of the department is really important. So whether you're in majors, whether you're in minors or the urgent care center, whether you're in a clinical decision unit or the observation ward, there's a lot of opportunity there to learn about, patients. So yes, resuscitation gets really sick patients. You will get to see and observe a lot, but what you may not get is that much of hands-on opportunities compared to a different area.
Brilliant.
So yep. I would definitely recommend that whichever area you are being allocated in emergency medicine, have your goals, what procedures you want to do, and liaise early with the consultant of the allocated to that area or the registrar, or find a person you could who could supervise you while you're on that shift to go through these goals. May not be that exciting. You may not see a serotonin syndrome every day, but you would still see sepsis. Or you would still see, infections or some mental health emergency. So, yeah.
Good. Brilliant advice once more. I think we'll take, should we take 3 more questions? Are there any here that spring out to you, Arjun, particularly?
So I think there are some questions about training. From my experience, I'm quite glad to help, so I'll answer that one.
Yeah.
It's, so the thing is, I trained in emergency medicine in India, and maybe that's why that could answer why I became consultant so young, is I had got all my competencies signed off. I had already done my Royal College exams while I was in India, training to be an emergency physician. And when I moved to the UK, it was mainly for experience, because I wanted to just see how emergency medicine is in the UK. However, since I had all the competencies, I applied for a training position straight after coming to the UK. And I got into higher specialist training. So that's how I guess I ended up becoming a consultant really young. So my advice would be, wherever you are working, whether you're doing a clinical attachment, whether you are actually just in a non-training role, please establish your portfolio. Please get your competencies, do your exams. Because when you go for an interview, it's not just the clinical stations that you have to pass. You have to show evidence of what you've been doing in your career while you've been non-trainee. So please gather as many certificates, CPD sessions, and have a good portfolio. That's what's going to score you the maximum in an interview and get you a training job.
Yeah, brilliant. Thank you. I think a lot of people ask questions about training, and particularly international students as well, so that I'm sure that'll be coming really handy. So we'll take 2 more questions. Arjun, any that spring will catch your eye?
So I think there's a lot of chat about EM, ACCS EM for medical students. Again, as I say, so as year 4, you would be doing emergency medicine critical care rotations. This is your best chance to actually get taster sessions. However, if you really think EM is a career for you, I would say you could speak to your supervisors, your clinical supervisor, undergraduate lead, whoever for EM is, and try to do some out-of-hours shifts, because that's when you have lesser number of people. So you will be more involved. You will be actually given more responsibilities, even as a medical student. So I would definitely get you guys to do twilight shifts or night shifts if you can, you're allowed to do. Because that'll actually give you a taster of what life is going to be as an emergency medicine doctor. Apart from that, I would also recommend, the Royal College of EM does organize taster sessions for ACCS, so which you can attend. And it just talks about what your training time, what the career is like. There are a lot of consultants like me talking about the day-to-day experience. So that's something you can look into. I'm not sure if they're running them at the moment because of COVID, but it definitely are doing a lot of online sessions. So that'll be something you can definitely get involved.
Brilliant. Thank you, Arjun. I think we'll take one last question to finish off. Any of these, I can keep scrolling as well. Sorry, we couldn't get through all of them, but whichever you'd like.
I think I know this is medical students, but I think there's a lot of physician associates. Do you mind if I answer one for them?
Yeah, please do.
It's
yeah.
okay. So physician associates, I think they have been really good. Like at St. Thomas's, we've got a lot of physician associates working with us, and they play a very important role, I think, part of workforce. So I would definitely, especially with EM, I would say it's a really good career. Whoever's worked with us planning to stay, and we actually recruited a lot more. It's good because you definitely get more consultant supervision, which the role says that you have to have consultant supervision. You have round-the-clock consultants available, and even out of hours, you would have a consultant on call and the registrar. Again, with physician associates, I know you have your training days, so that's a good time to catch up with the rest of the PAs in emergency medicine and just check, if the job's available. I think currently we're not getting PAs to do night shifts or out of our commitments, just because you have to have a consultant supervisor on the shop floor, as we call it. So yeah, you won't be doing out of hours work.
Great. Amazing. Yeah, I think when I was working at Tommy's, you had a ton of PAs, and I know that more have joined the team as well, and they're amazing, and they're across so many different specialties as well now. One of my good friends, actually, also called Arjun, has just joined Guy's and St. Thomas's A&E as a PA, so keep an eye out for him. So I think that's the last question, but thank you so much, Arjun, once again, for kind of helping out hundreds and hundreds of students and teaching us as well so many new things across those two cases as well. We're so grateful to have you here, and we'd love to have you back whenever you have a spare moment. So thank you.
Thank you for this opportunity, and I'm glad you guys like this session. And thanks for wishing me happy birthday.
Oh dear.